We have our panel moderated by Rocaille Roberts, who is the director of the Office of Policy and Planning and also a doctoral candidate at the UT School of Public Health. Rocaille.
Good evening, everybody. Good evening. Good to see you. So as Dr. Linder mentioned, I'm Rocaille Roberts. I think it's a great thing that I can be here to moderate this session on the public health system. What I'd like to do is just, really broadly define what the public health system is to get us started. Basically, leading up to this session, we've heard a lot about what happens in the healthcare system, right? We've heard about access to healthcare, the safety net system, quality care, financing around healthcare and the cost and payment and all of those things within the healthcare system. Today, though, we're going to take a different direction and talk about a very complementary system, and that's the public health system. If we were to look at the CDC definition of the public health system, we would see that it really refers to all public, private, and voluntary agencies that come together to contribute to really this collective body of public health services. And it's all based on the premise of what the Institute of Medicine has defined as really what we collectively do in society to ensure the conditions in which we can be healthy. So that's really just the broadest sense of what the public health system is about, but we're going to get into a little bit more details. Again, referring back to the previous sessions, there was a gentleman, I believe, on the quality of care session that talked about how if you look at the broad array of determinants, that 20% of the determinants of health are dedicated or I guess contributed by the healthcare sector. But when you look at the other 80%, there's about 50% of that has to do with the natural environment, social and economic conditions, and then about 30% that has to do with health behaviors, but even if you zoom that up, you can tie that back to social and economic conditions, the physical environment, and so forth. So in the public health system, we're really focused on that 80%. And we also, though, intersect with the healthcare system as well, and we're going to talk about some of that. But the primary focus is really around that 80%. So in thinking also about the scope of the things that the public health system is covering, it's very, very broad. So think about the drinking water systems and the fluoride that's in those systems to help protect against oral cavities, for instance. Communicable disease, environmental health, climate and health, maternal and child health, social determinants of health, all playing a role in just really helping us to better understand what the community really looks like in terms of their overall health status. So that's a little bit about the system. That's a little bit about the breadth of what public health really looks like and the sort of focus areas that all the players in some way or another address. Now let's talk about the players. And so with that, I'd like to introduce to you this excellent panel that will be speaking on a number of challenges and opportunities of what we see in the public health system. I'd like to first start off with Allison Winicki. Am I pronouncing that correctly? She is the president and CEO of the Immunization Partnership, but also plays a role at the University of Houston Law Center. Is that correct? Great. To her left is Dr. Umair Shah, who is the executive director of Harris County Public Health. And to his right is Dr. Schuler, who is a professor at Rice University's School of Business. And then we have to the immediate left of him, Dr. Peter Hotez, who wears several hats. He's the dean of the National School of Tropical Medicine and professor of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine. So quick round of applause for our panel. Okay, so what I'd like to do is now just transition a little bit into a greater understanding of what various players, what they really represent in the public health system. And so if we could then start with Ms. Winicky, could you describe sort of your, the sector essentially, and I think you wear a couple of hats too, right? So you can describe from any vantage point, but really the sector or the role that you represent in the public health system. Just name it and describe for the group what that really looks like.
Yeah, and so, when you talk about your definitions about the public health system, a lot of times people think of government agencies. So just the health department or the state health department or the CDC and things like that. But I love that, your definition you started out with is that really it's any actor, public or private, we all can have a role in the public health system. And so I represent the Immunization Partnership. We are a 501c3 nonprofit organization, and our mission is to create a community free of vaccine preventable diseases. And we do this through educating the community, advocating for evidence-based public policies, and supporting immunization best practices. And so, we are a really important player in the public health system, coming at it from this private nonprofit angle. So what we do is that we complement the work that they do in the government agencies and the health departments, and we do that sort of at the community level to reach out to the communities. Because really when you're talking about public health, it's, contrasting it with healthcare, healthcare is sort of the individual is the focus. It's sort of an individual with an illness or a disease getting individual treatment. But public health, it's community-based. We care about the community's health as a whole. And that's what we do in our organization, is that we look at, our mission is we're focused on the entire state of Texas. And we are trying to make sure that folks are protected from, infant all the way through the entire life cycle, to make sure that they have all of the necessary tools and resources and vaccines available to be able to protect themselves, their family, and the entire community.
Thank you. So Dr. Shah, could you provide your perspective? So one, to indicate the sector that you're representing, and what role specifically does your sector play in the public health system?
Sure. Thank you, Rocaille, and it's great to be here with fantastic colleagues, and it's great to have everybody here. See Dr. Bagley in the audience as well, and a lot of folks that obviously are friends and colleagues from previous years, so it's great to be here. What I would really say is that at the end of the day, what Allison has just mentioned is that really exactly what public health is. So she was talking about the big umbrella. This is public health. And she indicated in the middle of that there is a sliver that's the governmental public health, and that's my sector, right? That's the sector that I represent. And so Harris County Public Health is the county health department, very similar to other local public health agencies across the country. There are actually nearly 3,000 local public health departments across the country. And so we are one of those, whether it's a city health department, a county health department, a regional district. There are many different iterations of how public health in the governmental sector is at the local level. And certainly, as Allison also mentioned, local very much is related to state public health, our Department of State Health Services, and then moving up to the CDC, for example, as being the agency that we look at the federal level. But I think it's important to recognize that there's also a global piece here that the World Health Organization would represent, or PAHO, the Pan American Health Organization, represent global public health from a governmental sector. So we have governmental health that's going global all the way to local, and local all the way to global, in really a bi-directional fashion. The other thing that I think is really important is that we do think of, and we should be thinking about public health as really, especially in the governmental sector, that we oftentimes hear these terms population health. And so you're talking to a health insurer, or you're talking to a hospital or healthcare system, or even talking to a private provider or healthcare provider who says, I'm also working in population health. That's absolutely true, they are. However, when we in governmental public health think about populations, we think of large masses of people, the entire community, or if it's state, the entire state, or if it's federal, the entire country, or if it's global, the entire world. And so we're not thinking just of our patient population or just of the lives that we cover in maybe a health insurance plan, or just the individuals that are coming into a healthcare entity or healthcare system or hospital system. We're thinking of the entire community. And so Rocaille made the comment about the Institute of Medicine definition, which really was that what is public health? Public health is what we do to assure the conditions in which people can be healthy. And I'm paraphrasing because that's not exactly what it says, but it says something like that. And in parentheses, healthy, but I would also put safe, protected, right? There are other terms that come to mind that really recognize well-being at the end of the day and what that really means. The final thing that I would say, and this is really my favorite metaphor, is that because we're in Texas, right? Right? So yes, we are, and we are a football state, right? Everybody loves football. So everybody knows football in the sense of that's what really is the sport that resonates here. So I always think of public health as the offensive line of the football team, right? So healthcare delivery can be the quarterback, and EMS can be the wide receiver, and name it, all the other healthcare providers that could be the running back, et cetera. We are the offensive line of the football team. We're absolutely critical to the success of that quarterback being able to throw that touchdown pass. But I dare say, if I ask you who is number 77 on the New England Patriots, or who's number 75 on the Houston Texans, very few are going to be able to raise your hands and say, I know. But you will know Tom Brady, right? You will know other quarterbacks. Everybody is going to know Deshaun Watson, but people will not know the offensive line. That's public health. We're behind the scenes, we're largely invisible, but if we don't do our job, or if our job, despite us doing our job, something happens, then that quarterback is not able to really have a successful game. Here's where the metaphor breaks down. In public health, or in football, when you have a great game, a great season, the last thing you do is you get rid of your first line of offensive linemen, right? You say, you had a great game, you blocked for the quarterback, there were no sacks, we're gonna keep investing in you. But in public health, that's exactly what we do, unfortunately, is that when we have a great season, a great 20-year run, we say, you know what, tuberculosis rates, they're going down. Measles rates, they're going down. We don't need them anymore, so let's not build the capacity or rebuild or continue the investment in public health. And guess what happens? Tuberculosis rates start to go back up. So I really believe that that is the best metaphor for what public health is that we're largely invisible but absolutely critical to the success and well-being of a community.
Thank you. So you've heard a governmental perspective. You also have heard a perspective from the nonprofit sector. Let's move to Dr. Schuler. Dr. Schuler, could you share with the group basically the sector that you represent and its role in the public health system?
Yeah, so good evening, everyone. I'm Doug Schuler, and I'm in the business school at Rice, and I'm probably the person I would dare say in this room the least connected to the everyday occurrence of this problem. But what I study a lot, the fit between organizations and the environment, including individuals in the environment, and I think that my sliver that allows me to be in here is kind of Rocaille's 80%. So we've, together with Balaji Coco, one of my colleagues at Rice, we've been studying food insecurity in Houston for about 2 years. Food deserts, nutrition, food insecurity, there's many different labels. And one of the really interesting findings we have, and we're kind of in analysis and beginning to present these findings, are that there's many discrete interventions. Sometimes the interventions are done between a user and a private sector organization, a grocery store. Sometimes they're done a user and an NGO, so we have many in town. Brighter Bites, Urban Harvest, many more. Sometimes they're done with government agency. That's how I've met this crew. So Harris County Public Health is involved in many interventions, City of Houston, City of Pasadena. But the challenge is when we look for the systemic good, because again, there's a lot of investments, we tend not to see it. And we tend not to see it, I think, because there's nothing that binds together these interventions. There's either on the funding side, on the policy side, it's hard to get this big collective impact. So that's what we've been studying. We've been really studying kind of how these different interventions touch users or don't touch users, and kind of possibilities to kind of bind together different interventions that seem discrete. So I'm going to leave it there.
Thank you. Dr. Hotez.
Well, thank you very much for having me. Good evening, everybody. And like Umair said, I'm also very grateful to be up here with such a distinguished group of individuals. Some really my public health heroes. How do you define public health? I like to think of it as a complement to what your physician or nurse practitioner or PA does, which is, while they're the art and science of treating disease, I like to think of public health as the art and science of preventing disease. So there's a big emphasis on prevention. And while Dr. Shah said he represents a small sliver of what public health is all about, I'm going to respectfully disagree. I think he's front and center and sort of the bread and butter of public health as one of the tiers of public health, meaning that you look at the county and city health departments, and then on top of that, at the federal level, in our case in the United States, the Centers for Disease Control and Prevention, then scaling up globally to the World Health Organization, with the major common denominator being they're all grossly underfunded and don't have enough money to do the job that they need to do. So I often like to joke with Umair that my job is to be Umair's publicist, so he can get more resources to get the job that he needs done. So I'm an academic. I'm a dean here of a School of Tropical Medicine. And what we're mainly focused on is really to do the fundamental research and training in order to feed into the kinds of things that the county, city, federal, and international health departments are trying to do, really to both provide the tools that they need, as well as to inform on policy. So we're called the National School of Tropical Medicine, which really focuses on diseases of poverty. So what is a tropical disease? It's really a health disparity, and two, generally speaking, it's an infectious disease. So it's infectious diseases that disproportionately affect people living in poverty. So we're here in the Texas Medical Center at Baylor College of Medicine, the Texas Children's Hospital, and we're primarily focused on, one, doing things like outbreak investigation and understanding how the mechanisms by which diseases are transmitted globally and here in Texas, and I'll come back to that in a minute, and also to try to develop better tools to fight disease, to build better diagnostics and better vaccines. And I think for me, one of the big surprises when we moved, a group of us moved down to the Texas Medical Center 7 years ago, we came with the idea that we were going to harness the energy of the Texas Medical Center and build the next generation of control tools, vaccines, diagnostics, epidemiologic studies for diseases of the poorest people in Africa, Latin America, and Asia, not realizing the depth and breadth of poverty that's here, right here in Texas. So we call them tropical diseases. They're first and foremost diseases of poverty, and among the 4 or 5 million Texans living below the poverty line, one of the real surprising features is how much tropical disease transmission is going on in our state in terms of typhus and Chagas disease and toxoplasmosis, or as I like to say, all of the diseases that you've never heard of. But we find quite a bit of disease and poverty in this state, and that's one of the real interesting components of what we've been doing here to address public health right here in the state of Texas. The idea being we've taken that global health lens and flipped it inward, not only in Texas, but also in other states that comprise the Gulf Coast, so Texas, Louisiana, Alabama, Mississippi, and Florida.
Thank you. And so, you know, you have described much of your work as really targeting those diseases of poverty. And, you know, that could transcend, you know, from infectious disease or apply rather to chronic diseases. A lot of the issues here locally in our county, in our state, in the U.S. Dr. Shah, if you could you describe how health equity perhaps is something that should be addressed in thinking about diseases of poverty?
Sure, and I think Dr. Hotez can add to this as well. You know, when he brings, and I wholeheartedly agree with him, when he brings the lens of poverty and economic status into the mix, that really is the challenge that we have, is that oftentimes we don't. And we don't do that enough. And so we start to think about line items, and we start to think about, you know, these sectors of this is a disease, this is a disease, this is a disease, and we go down and we never really try to figure out a way to really integrate what's really causing all of these diseases or has a major contributing factor. And so poverty and economic status, as well as education and, you know, certainly housing and other kinds of socioeconomic factors really have a major play in all of these diseases that whether they range from infectious diseases to chronic conditions that really have a significant play in what we're doing. And so what I would say is that we've heard the term health disparities over the years, and really the literature and the field of public health has really moved in the direction of away from just the term health disparities and really to the words health inequities or the term health equity. And what I would just briefly say is that health disparities is, for all intents and purposes, just the descriptor of differences between health outcomes, not necessarily going into what the causes are, but really there are differences between different populations and or segments of a population and what their health outcomes are. And health inequities really are describing what I would say is that it's peeling the onion. You're trying to figure out what's causing those disparities, those differences. And that's oftentimes we find that they are inequities that are remediable, they're unjust, and they can be changed, that we at some point have the ability of making some change in our ability to make a difference. And so why is it that a certain population in our larger community has a lower life expectancy than another population simply by where that individual or community is geographically located, right? Zip code matters, place matters. And what we say in our department is that we really believe that there are 4 E's to equity. We believe there are economics, which is what Dr. Hotez just mentioned and Dr. Schuler mentioned as well. But we also believe in education is a huge piece of this, the environment, right? And that's the broad environment, right? This is not just the physical environment, the natural environment, but also the social environment, the built environment, and really thinking about that as well. And then certainly the last one is the piece that we believe is really critical is engagement, is the lack of engagement, lack of empowerment, lack of ability of making decisions or access to decision making. When you put all that together, that gives you that 4th E, which is equity. And so really in our minds, equity is really the state where all of us have at least the opportunity to enjoy the benefits and the fruits of what really should be optimal health in our community. And unfortunately, as we know throughout our world, so it's not just a local issue, but throughout our globe, that there are far too many people, far too many situations. And Dr. Hotez mentioned, 4 to 5 million out of 27 million here in Texas that are really not enjoying those fruits of the opportunities that we all believe is optimal health. So, if you go to the business sector, when you say equity, they're thinking about mortgages, right? They're thinking about, right? So you have to be really careful how you frame this. And you say equity, a lot of times there's a kind of a visceral reaction to some people, and even in the health setting or in political discourse, they think of equity as being a global term. But we really think about equity as being something that very much is part of what's impacting local Harris County and Houstonians, and we want to make sure that we can really impact those conditions.
Okay. Thank you. And so, you know, a health equity lens could also be applied to food insecurity. It could also be applied to vaccinations. Dr. Schuler, Ms. Winicky, is there anything you'd like to add to that?
Oh, well, so I can speak a little bit related to immunizations, particularly with health equity. So this is something that's really important. And so something, you know, in public health is because we are looking at the community as a whole, and however large that community group is, that it shouldn't matter about what zip code you live in, or your economic status, or your racial or ethnic background. We should all be afforded these basic, you know, public health necessities. We all have to have clean water. You know, we all need to make sure that we have immunizations available and ready to be deployed during, you know, regular everyday times as well as during emergencies. And so it's sort of these basic building blocks that's what's really important, that we really want to emphasize when you're talking about health equity issues, is because the public health, these basic public health building blocks, that's what allows us to even grow and have greater health outcomes. But you have to build this strong foundation, and that's what we're doing with public health. When we're looking at these equity problems, is that's what we're looking at, these social determinants of health issues, because we're trying to dig down under the surface of that foundation to find out why it's so, you know, uneven. Because until we can get that a nice firm foundation, then we're not going to be able as a community to build up and have positive health outcomes.
Dr. Hotez, you want to chime in?
Well, I'll just say, you know, I think the other, you know, when we talk about health inequity, it's very much tied to concepts of social justice. I think, you know, and this was really said very eloquently by Martin Luther King, I think in 1966. He said, of all forms of inequality, injustice in healthcare is the most shocking and the most inhumane. And so this really gets to what such a central component of public health here in our city is the depth and breadth of poverty that we see in some of the historic wards and elsewhere. And the disparities are shocking as well. And I think this is important for the conscience of Texas Medical Center. You know, the Texas Medical Center is one of the most advanced, most sophisticated medical centers in the world. It's been an amazing place for us in the last 7 years, and we can tap into scientists and physicians working on almost any aspect of biomedical science. But what's equally shocking is when you go walk a mile away from the medical center, you see some of the worst healthcare indices of any major city in the United States. And I think this really gets to the urgency of stepping up public health in a much bigger way than we're currently doing. I'm not saying I have a solution for it, but I think this is a critical component.
Yeah, and I would just add, you know, one role that governmental public health has is really to help encourage others in the public health system to work outside of the four walls of their institution. So that could mean encouraging institutions within the Texas Medical Center to really look at the community conditions in which patients are coming from, and working with community-based organizations to help meet some needs that the healthcare system may otherwise not be able to meet. Dr. Schuler, is there anything you'd like to add?
Yeah, I'd just like to follow up on two of Dr. Shah's points that I thought were quite excellent. One was about these 4 E's. So if you recall, he talked about economics, education, broad environment, and engagement. And this is one of the, and working together. And when they don't work together, this is a lot of times why we see interventions fail. So for instance, not to demonize a particular one, but I want to put an example out there so it's vivid. So in many cities, including Houston, there have been attempts to go into kind of convenience stores, corner stores, and put in, typically in low-income neighborhoods. and put in fresh fruits and vegetables. It's seen as a way of kind of some type of remedy for something the private sector is not doing. Those stores right now aren't purchasing those. They don't think their customers want them. Big retailers that we would typically associate with fresh fruits and vegetables, the H-E-Bs, the Krogers, they're not interested in those neighborhoods with the formats of stores that they do. And again, not to demonize them. They're doing what they do. They try to make money in the grocery business. But one of the challenges of some of these interventions, even if you're successful in bringing fresh fruits and vegetables to these locations, has to do with some of these other E's. So for example, typically they're not there for economics. So if we subsidize the price, maybe the county helps do that, or a grant helps do that, or even the company, the retailer helps do it. You still need an education piece. How do you use those vegetables? A lot of people don't really know what to do with all that produce. There's a lot of stigma to produce use, and so I'm sure people in this room know that better than I do. The built environment. Again, one of the reasons that we see many kind of convenience foods in many neighborhoods, right, not only exclusively low income, is because they work for lifestyle, right? So, it's 6 p.m. Probably we're kind of hungry. Probably we don't want to go home. There might be kids at home. They're going to be cranky. What am I going to do? Is it time to do that shopping? And all these things work together to kind of show why certain types of interventions may really have challenges. And I think if you're not honest in addressing all those 4 E's, it's almost guaranteed this intervention is not going to work. One nice thing, and then I'll yield to my colleagues and to our guests, is the Houston Food Bank has a program called Food for Change. And I don't know if any of you know that. If you go on the website, you can see it. Very interesting pilot projects. And they pick up on one of Dr. Shah's points about kind of digging deeper about inequities. So 2 particularly interesting ones is there's a food scholarship program that they're running as a pilot, and there's a food prescription program, and Harris County Health is involved in both those, one of those, both those programs. And these are looking at the root cause. So why is there some kid who's at Lone Star College, not eating well, not getting these things? And I think what the food bank is finding is that people are using food as they're substituting food for rent. And so, and to some extent, so if the food bank can kind of use its food supply and work with the college and other partners like the county and others, we might be able to kind of dig deeper. So there are these things happening in the community, but they tend to be, it's almost brand new stuff.
Mm-hmm. Yeah, and so, that just brings up a point of, access to food should not really get in the way of access to education. And that's what the Food for Change, at least one of the really focus areas for that initiative, is really honing in on.
And I think a good illustration of how social inequality leads to health inequality was really demonstrated during the concerns about Zika virus infection taking a hold in South Texas and in Houston back in 2016. I would take journalists through some of the poor neighborhoods around Houston, whether it's the Fifth Ward or in Aldine or Sunnyside or Acres Home, and say, okay, let me explain to you why I'm concerned about Zika virus infection. And say, well, let's look at the homes. You'd see dilapidated housing with no air conditioning and no window screens. Guess what's flying in through the window screens? Or I'd explain that Aedes aegypti mosquitoes that transmit Zika virus love nothing more than discarded tires that have a little bit of water in them. That's Zika heaven. That's Aedes aegypti heaven. And sure enough, guess where all the tires were being dumped? In those poor neighborhoods. And then you have the fact that unless you have good access to health care, you could have a fever and a rash that could be very subtle. Unless you're seeking health care and have easy access to health care, you're not going to get diagnosed, and that's the case as well. So I think something like Zika virus infection was just a great didactic teaching example of why social determinants are overwhelming as a driver for inequities in public health.
And that, if I can just add, that threat from Zika may have diminished, but those opportunities due to poverty and social conditions remain.
Right.
And so all these
next
diseases,
time around it won't be
that's right.
Zika, it'll be
There you
dengue,
go.
it'll be
That's right.
you name it. So.
And I think that's one of the, and if I can just add this to what Dr. Hotez is saying, that's one of the big challenges that we have, especially in the governmental system, is that oftentimes we're very reactive, right? So there is an Ebola, and so then we, oh my gosh, and we do all sorts of things, and then funding people start to say we need to do more and get more funding, and then funding comes, but whatever the issue was may have already been handled, but now the funding comes in, so this capacity building. And same thing with Zika, right? So Zika occurs, and Dr. Hotez and I were in the trenches trying to fight to get funding, and I think I've been quoted as saying the goose is cooked, we're not getting this funding, and all sorts of things, and I probably shouldn't have said. And I know Dr. Hotez said worse. I
used a word that rhymed with cooked. So.
That's right. That's one of the beauties of working with colleagues, is that sometimes you recognize that if you say something bad and you really think it's bad, just wait till you walk over to Dr. Hotez's quote. His quote is going to be significantly worse than that. So, but that funding, again, was after the fact and not when we really needed it. And so it just reminds me of the fact that oftentimes in public health, we are really dealing with whack-a-mole. That you have a disease that comes up and you whack it, but by the time you actually get the hammer to whack it, it's too late because that disease has already gone away, and now the next disease comes up. And so we play reactive catch-up rather than proactively investing in our public health system and the capacity throughout our system to ensure that the system is not like this, very laser thin or rock solid margin thin, but that it's big and it's broad and it's well capable and the capacity is there, so that when you have the next exotic disease, or not even so exotic disease, but the run-of-the-mill disease that's taken off, you're not having to stretch as high because the capacity is there and you're stretching just a little bit to do the surge activity for that response. Instead, what we're doing is we're oftentimes playing catch up because we just have very, very thin margins, and so we're having to reactively try to put those dollars in and or fund the capacity.
Well, this is the problem. They keep you so shorthanded that you don't have enough money to walk and chew gum at the same time. So now that Zika's transmission is way down in the Western Hemisphere, basically Zika is so 2016, right? So you're just not, you don't have the tools now to continue fighting it.
That's right.
And you're on to the next crisis.
That's right.
And I'll just add, I mean, this is a terrible way to run public health. Crisis. So I'll tell you, like, Dr. Shah says, there are buckets of money. So we had our Ebola money, and it's like Ebola is an emergency, and we got emergency appropriations down from the federal government, and we spent it, and we did all this, public health preparedness stuff, and then the Ebola money started coming out. Well, what's the next disease? Here's the Zika. And so then, we're out of Ebola money, and so, but we need some money to fight this. So instead of having, what we should have is like our robust public health prevention fund that's, a fund that we'll be able to, use and tap this money whenever we need, instead of every new thing. And like Dr. Hotez says, there's going to be another neglected tropical disease. Something else is going to come down the pike. And, now that, they're like, well, you don't need money for Zika anymore. But we need money for public health, period, to make sure that we have this infrastructure stable and robust enough to respond to whatever is coming down the pike. Because I guarantee you, something else is coming down the pike. We haven't tackled all of our public health problems. And I just feel like we need to really let our policymakers know that public health is important. We're sort of a victim of our own success because the folks doing public health are so good at it and good at protecting folks. But the only way that we're able to do that is if they keep supporting and funding public health, you know, at stable, high levels so that we're never caught out on a limb and be like, you know what, something terrible has hit and we just don't have the resources to respond. We cannot put ourselves in that situation.
Question. So, what do you think would like end this continuous cycle?
Well,
Good question.
so sometimes people say we sort of run from crisis to crisis, and it's like sometimes they're like, well, this will be the crisis that really, you know, gets folks to open up and realize that this is the issue. Although we've been doing this for quite a while, so I don't know if that's going to take. They always say, you know, the next epidemic, that'll be the one that really opens up folks' eyes, that they need to, you know, put some long-term funding in place. But I think that, you know, my own personal thought is that it's primary election day here, you know, polls close in 45 minutes. We elect.
But don't leave.
Right.
You should have voted already.
Right. You know, we elect our officials to go to the legislature in Austin, you know, to Congress in D.C. to carry out what we think is important. And if we think public health funding is important, we should elect folks that also think public health funding is important, and we should support those folks. And so, you know, that's coming from, you know, the policy side. You know, that's something that I really believe is you know, put your money where your mouth is. If you really, you know, public health funding is important, go and tell your elected officials, I'm a constituent, and it's important, and I care, and I vote. And I voted in the primary. But I know you have things to say about this, too.
You know, I think from one, to answer your question, is that it is that we've had success from the standpoint of, you know, things that have not happened. It's a challenging conversation because, you know, when you are treating the 5-year-old that has leukemia, you can very quickly put a poster up of this 5-year-old and say, here's the poster child for cancer treatment. But it is a harder concept to put up 1 million children and say, here are 1 million kids that we prevented cancer in the first place, right? So do you show all 1 million? Do you show 500,000? Do you show 200? Do you show 2 of them? And so it starts to become diluted. All of us have, you know, our heartstrings emotionally go out when we hear of a story that's so compelling, and we wind up actually being willing and wanting to put our heart out there and our resources out there, or our political capital out there. At our department, this is the one thing that we have done, is that, so we believe strongly that public health is largely invisible, okay? And when anything is largely invisible, folks do not see, because it's invisible, the value, right? So when you don't see the value, you don't understand the value, you don't commit to actually then doing the last thing, which is really either having policies that are in favor of it or investing in it. So we believe at our department that we have to raise the visibility. When you raise the visibility to elected officials and or others, partners, that they then understand the value, so raise visibility, value, and then the third piece is we hope then either policies are in favor of and or you have dollars that would be supportive of, so you would then see it as the investment. The challenge is that far too many local health departments, or health departments in general, state and federal, do not feel that that is their job. They do not feel they need to go out and look for resources or raise the dollars in the way that they should. So we have actually, in a disciplined way, we have actually forced ourselves to have a communications team. We actually go out and film when we're out doing things. We have 75 YouTube videos that we put on last year. We did this, many of those were because of Hurricane Harvey, but in addition to that, we did that because we really felt strongly that when our folks are doing their job, it's largely invisible, and we have to raise the visibility. And that's the only way we're ever going to get out of this, is raising that higher level of understanding of what we do.
That sounds great.
And
So
Can
I'd
I
like,
add one thing?
yeah, I'd like
So-
to, before we do, I do want to just give you an idea of format. I probably should have did this a little bit earlier. Some questions are going to be directed towards the panel, but from time to time, we will want to hear from you if you have questions. So it won't be just all discussion with the panel and then Q&A at the end. So I'm seeing a couple of questions, actually 3. I'm going to start with Tanweer back here.
Actually, I promise this was not a planted question. So just out of curiosity, actually, well, I guess it could have been anyway. No, it wasn't actually. I'm joking. But anyway, so as far as actually things that are more in the public eye, how has that affected all of your work or things you've seen in your work? So the 3 big things that have happened in recent years, you have Harvey, Hurricane Harvey, you had the opioid crisis, and you have the school shootings. What has that done as far as like your work and funding as far as public health goes?
Who wants to take that one?
Well, I would say, the biggest, for me, the biggest crisis has been neither of, really, I can't say any of those particular 3. It's the real crisis, which is looming now, is the fact that, Umair has been so successful in public health that some of our major threats are indeed invisible, and we're now allowing our guard to let down. So one of the great victories that we've had in the United States is the elimination of childhood infectious diseases. We've eliminated measles transmission in the United States, diphtheria, pertussis, tetanus, the list goes on, Haemophilus influenza type B, polio, and so we no longer see those diseases any longer for the most part. And this has built in a complacency or even outright hostility towards vaccinations, and it's particularly acute now in the state of Texas, which has really become one of the ground zeros of non-vaccination due to a lot of aggressive anti-vaccine activities in our state, led by both political action committees as well as specific individuals. So while overall immunization rates in the state look pretty good, if you were to look at just the number of the percentage of kids receiving their vaccines, that doesn't look so bad, but it masks a very scary situation that we now have in certain parts of Texas, especially in Austin, up in Plano, up in Denton, where we have schools with 20, 30, 40% of their kids not getting their vaccines, to the point where it's almost guaranteed we're now going to see a return to the past. We're going to see return to outbreaks of childhood infections. And historically, because the most transmissible infectious disease is measles, that tends to be the one that pops up first. So it's very concerning that we can see this train coming 2 miles down the track. Here comes the train, the measles train, where it's coming, and we don't seem to be able to do anything to stop it. And we've also seen this with influenza across the United States this year, including Texas, that the vast majority of the 100 children who died this year in the 2017-2018 flu epidemic did not receive their vaccine, even though it's not preventing flu cases so much, it's preventing flu deaths. So we have to fix what's now a very broken system where children in many parts of the state are no longer getting vaccinated and doing it for reasons that which we can subsequently talk about.
And there's a question back here.
Yeah. As you all know, Dr. Weston is running for Congress. He's stated that millions will lose their access to health care if Trump has his way, according to his website. My question is the organizations that y'all work for and the organizations that you're affiliated with, I noticed that y'all do not endorse officially any candidate. And I was wondering, it seems like money is a root of many of the problems that you are discussing here through funding the federal government. Why don't your organizations, such as Harris County Public Hospitals, et cetera, officially endorse a candidate, that you guys are on the same page, the same book. I mean, just to simplify it, just have a press conference and say, we stand by folks like Dr. Weston, and that's in the story. And perhaps that would influence votes, and perhaps that will solve many problems just in a pure, simple way to look at it.
So that's a great question. I would say that it's always challenging in the world of governmental public health to get too much into the political, the partisan politics, I guess is the way I would say it. And so there's a big debate oftentimes that's happening in public health agencies about lobbying versus advocating. Right? Lobbying really being that like you saying, exactly this concept of politically going out and endorsing either these strong either candidates or positions or what have you, advocating, saying that it's not really about the candidate or the particular party. It's really about we're trying to get a job done and we're advocating for a position. The position being that we are obviously in it for the health and well-being of our community and doing what we can short of going to what your point is, which is to say we're endorsing a candidate. If you kind of follow it to the nth degree, it becomes then really challenging if you started to have governmental agencies starting to endorse, especially when you start to have on government time, because now people can then accuse you of saying, well, why are you in some sense bringing your personal favoritism and or some personal views in? Now, on non-government time, non-use of government, products, materials. I have an attorney to my right here, so I'm not looking at her. But non-use of government, pens or phones or whatever, electronics, et cetera. That if you are a private citizen on your own time, not using governmental property, you can do what you want to do from that standpoint. But you can't represent as I am X agency representative saying this, because that gets you into some significant amount of hot water and certainly in many ways is illegal. And so you're prohibited from doing that from that standpoint. The other piece is that even if there isn't the legal prohibition, it's just not a good way to do things. And the reason I would bring it up this way is that I believe, regardless of what party affiliation that you're either endorsing or feeling strong affinity towards, I believe you can actually build bridges to almost, that's a key word, almost anyone. And our job oftentimes, and this is the biggest challenge that we have oftentimes in public health, is that we oftentimes have very much people who are passionate about what they do. They're so excited about this is the right thing, there is a moral compass, this is the right thing to do. And they forget that there are power dynamics and power structures in our country that are very much about a two-party system. And that two-party system is that you have to work with both parties. We cannot put ourselves into, in fact, I think it's a complete mistake if we only endorse one party and or one system, because what we have done then is really made it hard for when potentially the other party, whichever party it is, wins or is in the power structure, that you have no longer an opportunity to build a bridge and have that conversation.
Yeah, I would say that's absolutely true. I mean, in the 11 years I spent in Washington, I quickly learned the only way you get anything done is to reach across the aisle and reach across to both sides of the party. We were able to get a lot of legislation advanced to treat now 1 billion people for their neglected tropical diseases. And then there's a real danger when you do politicize health, and we're seeing that now play out in the races tonight. We've got now a political action committee, an anti-vaccine political action committee that is using the language of the far political right, the Tea Party, in order to gain ascendancy. And in so doing, they've actually been able to get the backing of the governor and the lieutenant governor, who by default are backing candidates running on anti-vaccine platforms. So this is an example of when things go really wrong when you do politicize health.
Yeah.
Now I got to say, so I teach business government relations at Rice. It's really where I do most of my research, and typically we would we would counsel. So some of the stuff you asked is just illegal. That would be
Right.
the really easy answer.
Well, not for us, because
Yeah.
we're
Yeah.
tenured professors. We can say pretty much whatever we want.
I work
That's why I
for
said I'm looking at my attorney to the right
I
here.
work for a nonprofit, so we can't do that. But there's some very interesting research in political science about this, the status quo bias, right? And to some extent, I think you don't need to be a PhD in political science to understand that policy works at a frustratingly slow rate. Of course, it was designed that way by the founders. It's hard to pass stuff at almost every level of government. And one of the ways to break the status quo isn't necessarily to invest more money, it's to get new players. So typically we would tell companies, look, stay out of elections. All the stuff that you just heard from Dr. Hotez, you play with whoever it is. If it's Republicans at the dance, play with Republicans. If the Democrats come back, you play with the Democrats. You play with incumbents who control committees. But on the margin, if you're advocating perhaps a candidate who you think likes healthcare and you're in healthcare, may not be bad, right? But again, there's so many avenues to throw money into politics. I mean, there's very clever election law people who gave you a lot of instruments. You don't really have to do it through your organization. You can do it as a private citizen and other ways.
Yeah, and I'll just add, so you've heard the 501c3 nonprofit organization. Well, that actually is section 501c3 of the Internal Revenue Service Code. And so they're actually, and we represent those types of nonprofits, governmental agencies, and academic institutions are also oftentimes 501c3s. We are actually prohibited in federal law from what they call electioneering. And it's basically, you can't endorse candidates, you can't rate candidates. There are other organizations who do not have that 501c3 designations that they are able to do that, but a lot of sort of the big mainstream organizations, that's why you don't see them coming out and endorsing a candidate. And also, especially in government, they're prohibited from state laws as well, because you have to, what's the saying, like, dance with who brung you. So, like, whoever's in power, they're going to be the one who's giving funding. And so I really like to say, and I think this is particularly true in public health, is that, public health is too important. It's universal. It impacts everyone, that you can't, you have to stay above the political fray. We deal with politics. We have to understand all of the different political, issues that are going on and understand all the players and be able to work with them in constructive ways. But we can't get dragged down into politics, because that's not going to help us to be able to, work across the aisle, work with whoever the stakeholders are, and educate. A lot of what public health is, it's about educating policymakers, educating the public, making sure that folks are aware of all of these issues, and we can't burn any bridges, because we're here to help everyone, we're here to work with everyone, and whoever's in power, we want to make sure that we have that connection to advocate. And a lot of what advocating is just educating. It's like almost like another word for educating about what are the important public health issues and what sort of help we need from policymakers.
So I saw, so Dr. Begley, I want to get you next, and then do you have a question still?
Somebody else.
Okay. So Dr. Begley first, and then we'll get your question.
Okay. I think many of the people in this room are in the part of the healthcare world that serves low-income populations, disabled, elderly, and other vulnerable groups. And it seems like in this world that there is quite a bit going on to encourage us, to incentivize us, to require us to begin addressing the social determinants of health as a part of standardized, regular medical care. And I was just wondering, with Medicaid reforms and Medicare payment policies and federally qualified health centers and and the local indigent healthcare programs and charity care programs. And I was wondering if you see this as a positive movement that might get us down the road, Dr. Schuler, at least an inch or two towards some kind of intersectoral interventions that might be effective, or if not, if this is just, too incremental, not getting us there, what do you suggest could be done to move us in that direction more quickly?
Well, I wasn't sure if that was to Dr. Schuler, but what I would say is that any move towards what we call it's not a complete stream because it actually is working in a number of different ways, but we like to think of healthcare delivery or end outcomes as downstream, and if you start to think about social determinants of health and really looking at root causes as being upstream, but we know it's not a complete continuum. It is actually working in a multifaceted way, and it's really a number of streams that come together. But if you look at that metaphor of upstream, downstream, we do believe that it is the prevention piece and the upstream factors that very much are the elements that impact many of those conditions. And this is something I learned in your course as I was a student at the School of Public Health multiple years ago, is that at the end of the day, it really is. Yeah, I know. That was a compliment to you. That's right. Yeah, the third multiple. Is that at the end of the day, we do recognize that prevention and really at the root cause is the way to go. But the challenge is that oftentimes terms, and I know my colleagues will recognize this very quickly as well as all of you in the room, is that terms become buzz terms. They become the latest fad, the latest craze. So everybody right now is talking about health equity. Everyone is talking about social determinants of health. Everybody, and it's the sexy thing to do.
Don't forget health systems.
And health systems. Health systems strengthening, right? And
integrating public health and healthcare.
That's right. Where I see the best opportunity is that when we can work with sectors that are actually not in health and really get them not to be speaking health language, but to be speaking their own language and helping to drive health and well-being in a community. And what that means is that, so if we're looking at the education sector, and so education is not, we always say health in all policies. To actually a lot of folks, that's a very threatening term, health in all policies. It actually means health is trying to take over. And I've even heard, and I was in DC last week, where it's health imperialism. We're trying to take over the world. That's actually not what we're trying to do, but that's oftentimes what it is, is construed. So if you actually have the education sector whose job is to educate students, it's not just health that we think, it's to educate students. But in the process, if they can move the needle on education in a way that actually promotes the health and well-being in a downstream manner, it actually helps us in health do our job better. So I think it's really these public-private partnerships, but these multi-sector
on that issue,
partnerships
Dr. Shah,
to
practically all
Yes.
what I'm seeing is that we're being asked to hire community health workers. We're being asked to have case managers. We're being asked to have navigators on our healthcare staffs. We're being asked to have pharmacists and behavioral healthcare providers integrating with our medical providers on our healthcare staff to, provide a more holistic approach that incorporates social factors in the patients that we're seeing on a regular basis. Is that enough? Is that getting us any further down the road towards this intersectoral? I mean, how far can we go in terms of education with a patient when we're seeing them once every 6 months or something for their diabetes? I mean,
I think it's getting the best we can in our sector, but we can't do this unless we get out of our sector. I guess that's what I'm saying is that, so if I'm a physician, this has happened oftentimes in, whatever my 15, 18 years of clinical practice, and I remember that, the patient would come in, Mrs. Johnson, you're overweight and you're still smoking, you need to stop smoking, start exercising. She comes back 6 months later, say, you haven't stopped smoking, by the way, you haven't exercised a moment, not knowing that going back to the community conditions in the park that's near her house is dilapidated, there are dogs that are, that are about to bite, she's worried about her kids, she's got too much on her plate, all these other things that are happening. And so she comes back, and I call her non-compliant, or the best term now is non-adherent, right? So we start labeling, but that's where we need to get to where you are, Dr. Bagley, in terms of the health sector. But what I'm suggesting is that we really need to reach out of that sector and make sure that the business community, the education community, and the housing community, that they're also thinking about all of these areas and working back to almost encourage the relationship back with public health. And so in the federal system, it's right now, who got the most out of the increase in, out of the budget, the president's budget that was out there? Obviously, health did not do very well. NIH got a little bit of a bump, right? There was a bump there, it's a tiny amount.
Yeah.
But you know who got the most bump? DOD, Department of Defense.
Yep.
So now, but if we're just in our silo in our sector and we don't recognize that DOD, who by the way have had, what is it, that 60% of recruits are unable to actually meet the fit test? That if we don't believe in that as being an issue that we can help and work and partner with DOD with, then shame on us.
And certainly you see this, you know, when I work in low resource countries, developing countries. You know, the game changer in global health that began in 2000 happened not because suddenly the ministers of health woke up and they realized they have to take on HIV, AIDS, malaria, and neglected tropical diseases. It's because we were able to finally get to the ministers of finance in those countries and show them how cost effective it is, and not only cost effective, but economically dominant cost savings to apply those health interventions. Then things started to move. So unfortunately, ministers of health, and I guess you're the Minister of Health of Houston, are not empowered to get the resources that they need for that purpose.
The Surgeon General, we met with Dr. Jerome Adams last week, and he said that sometimes I wish that instead of calling yourselves health departments, and he was obviously challenging in this comment, instead of calling yourselves departments of health, I wish you would call yourselves departments of economic or community prosperity. Right? And his point being that we have to get to what Dr. Hotez said, is that the end of the table in the global spectrum, the Minister of Health is always the furthest away from the decision makers, and it's the economic minister and the defense minister that are right there, and that happens locally as well as globally.
So there's one question here. I'm going to have you ask yours, one question here, and then we're going to go through a few other questions for the panel.
Thank you. My question is for you, Dr. Hotez. You talked about the vaccinations or immunizations and being a problem in Austin, Plano, Denton, with a 30 to 40% not getting vaccines. That is a substantial number. Who's accountable for that? Because in listening to all of you and to you in particular, it sounds to me like there's a lack of accountability in terms of that number being so significant, so large. Who's accountable? Would the city mayors be accountable, or a minister of finance of some of these cities be accountable? Because without accountability or holding someone accountable, it's hard to move the needle.
I think what we're seeing are two pieces to this. One, we have a very aggressive anti-vaccine lobby that uses misinformation to provide false information about vaccines and alleging links between vaccines and autism, even though there is no link between vaccines and autism. And I get involved in this a lot because I'm not only a vaccine scientist, but I'm also an autism dad. My youngest daughter, Rachel, has severe autism and other mental disabilities. So I spend a lot of time countering this phony information that's being put out there. So you have people like Andrew Wakefield, who's directed this very slick documentary. He's based in Austin, called Vaxxed, From Cover-Up to Catastrophe. And it's a very compelling, scary movie. And you have to take a step back and you realize it's all totally made up. There's absolutely nothing true in the movie, and yet this is being put out there as a real documentary. So there's a deliberate misinformation campaign going on. And then you have a political action committee in Texas called Texans for Vaccine Choice that's actually lobbying on behalf of candidates. They're in Austin all the time when the legislature's in session. This is what Allison is going up against on a regular basis. So you have a very strong anti-vaccine lobby here in the state of Texas. Countering that, we have too much silence on the part of our elected leaders. And it happens at the federal and at the state and at the local level. So at the federal level, unfortunately, the U.S. Surgeon General says nothing. The CDC director, head of the CDC, says pretty much nothing. You can't say that, but I can say this. The Health and Human Services Secretary says very little or nothing, and the White House says nothing. And it's nothing against the Trump administration. It was true in the Obama administration. It was true in the Bush administration before that. So you have this kind of wall of complacency and silence not kind of pushing back. So now in the US, we have 18 states that allow non-medical exemptions for reasons of personal belief or philosophical belief. It used to be 19, with California being the 19th one. And then they had a horrific measles outbreak in Orange County and Marin County. And finally that woke up the state legislature to say, enough. No mas, and so they closed those loopholes at great political cost. But in places like in Texas and Washington State, it's still very strong. And it's interesting, it comes in different political flavors. So in Washington State, it's actually, or in Oregon, where there's a very strong anti-vaccine movement, they use the language of the political left. It's sort of peace, love, granola, we have to be careful what we put into our kids. And here in Texas, the language is coming from the political right. They use buzzwords like medical freedom or choice. And even though, from my perspective, vaccines are sort of fundamental rights of kids. It's a fundamental right of a child not to have to worry about getting measles and everything else. So it's become a huge issue.
Yeah, I would add, talking about, who has responsibility. And adding to Dr. Hotez, I think it's us. And it's us and our complacency, like he said, and our, we've elected folks in our Texas legislature who they actually expanded our ability to have non-medical exemptions in the state. So there's basically two types of exemptions to vaccines. The medical ones, if you have a medical contraindication, they cannot be vaccinated. And then non-medical. And under non-medical, those include things like religious exemptions. So a lot of states allow for some religions do not support vaccines, and so that's considered legitimate. And then we have what we call personal belief, and that's like everything else. And it's like, I'm not feeling like doing vaccines today. You don't actually have to have any kind of legitimate reason. And so Texas in 2003 legislative session, we expanded that so to make it easier to not have exemptions. And since then, it's been like an exponential growth in the number of exemptions that we have in our schools. We have it's about 53,000 students in Texas right now with these personal belief exemptions. Not the medical ones, not the religious, but just the personal belief, I don't feel like it. That's more kids just in one school year in Texas that are born in the entire state of Oklahoma every year, or the entire state of Oregon every year, or the entire state of Kansas. It's like half of our states, their birth cohort every year is less than just the number of kids that we have who have these personal belief exemptions.
And that's not counting the homeschooled kids, and we don't even know
yeah,
what
that's
that
just,
is.
yeah.
Right.
And there's, tons of homeschool kids that we don't even have the data on that. And so, but we allowed this to happen. So, we elected policymakers and they went to Austin and they said, sure, loosen it up, loosen up the requirements. And so now we had a measles outbreak in Waxahachie last month. 6 kids came down with the measles. We shouldn't have anyone in Texas come down with the measles. We shouldn't have that at all. There shouldn't be any kind of outbreaks. We've had over 4,000 people have died of the flu in Texas this flu season alone. We shouldn't have any flu deaths. This is preventable. All of these things are preventable.
And if you ever want some cheap entertainment, since I'm out there sort of combating the anti-vaccine movement, just Google my name and autism or anti-vaccine, and you get some fabulous memes. They've got pictures of me. They call me the boy who cried wolf because I'm exaggerating measles. So measles was the single leading killer of children in the world before the Global Alliance for Vaccines and Immunization. And they're peddling a book called Melanie's Marvelous Measles, saying it's a good thing to get measles. So they call me the boy who cried wolf. As long as they use a nice picture of me and I don't look fat in the pictures, I don't mind so much. But it gets much worse than that. So
we've spent decades really looking for silver bullets, what I call them in medicine. Some way to prevent or some way to treat, and here we have the ability to do that. And now folks are saying, you know what, we're not going to, and that's a big issue. Whether you're a public health pro, not this, that. It's just in medicine, we have looked for years. We have spent so much to get to a point where we can eliminate it. That's the reason I went into public health, was the WHO eradication of smallpox. I mean, that was the reason I went into public health. And I have to be honest that a lot of folks, and Dr. Hotez said this very nicely, people forget because those diseases are not around anymore, and so people forget how bad these diseases truly can be.
So one more question from the audience.
I guess this gets into the engagement piece. I work in the field of substance use, and we put out a documentary, and it's about adolescent recovery. And what we really learned was, and the professionals who worked on this already knew this, was that you can't go in and tell a community what to do. It's got to come from within the community itself to want to change. So with all the different types of communities in Houston and public health, and as you said, you can have the best intervention, but unless the community really, there's a champion in the community, or the community really decides that they want to do something. I mean, do you come up across this? Have you found ways to work with this? That's kind of where I am going with this question.
Yes. The short answer is yes. I would say that you have to look for community leaders. And and even the real concept of role models or champions within the community. So it doesn't always have to be the leader. It can be other champions that are there. But yeah, I mean, I recognize that if I tell you to eat an apple a day, you're going to be like, yeah, Shah's saying an apple a day. Joel Osteen says eat an apple a day. All of a sudden, there's a whole group of people that are going to say, wow, this is something in the sermon. Or if J.J. Watt says eat an apple a day, right? It all you start to really think about the value proposition of who we actually have as part of those systems. And so I would just really recognize that it's not always us, but we have to be at the table, but we have to also recognize that there's a currency of transparency, trust, and that is really important, that we recognize who those leaders are, who those champions are, and work with them. So it oftentimes is that we may be steering from the back of the bus, and that's fine as long as that the work is getting done.
If I could, it's a little off mark, but it's quite interesting. So the company Cemex, they make cement, building materials. They had a program in Mexico. They're trying to make money, basically, in kind of secondary, tertiary parts of large cities where they didn't have very good access. And they basically parked essentially a set of professionals, like I would imagine the people in this room, and they parked them in the community for about a year to learn how the community worked. And they set up this program called Patrimonio Hoy. They recruited basically local women who had huge kind of social capital in the community. And that's how they drove the whole program. If you look on YouTube, you can see a few videos about it. But I think it really speaks to, there's a very nice book by a guy named Everett Rogers. It's called The Diffusion of Innovation. I mean, it's not really nice to read because it's really fat and kind of redundant. But the first chapter is good enough. And they're actually about public health interventions. And essentially, the bottom line is, if the community doesn't like what they hear from these strange people on the stage, you got no chance. You just got no chance. So it's a real call, and that book's interesting because it's like, why do people accept certain things and reject others? And I think a lot of those insights are about because whatever I accept has to work within my worldview.
And among the anti-vaccine community, there's a stunning paranoia about the government and fear of the government and really distrust of the government. So, if you read any of the anti-vaccine websites, so much of it is they're saying the CDC or the health departments are in the pockets of industry and they're getting paid off. So much of it builds around this phony conspiracy theories, but it's very effective.
Yeah, and your point is well taken about, having, meeting community needs. So we do a lot of education for community immunization coalitions. And these are organic in their communities that they develop. And so the needs of an immunization coalition down in the valley are completely different from a coalition in East Texas. And so we recognize that, and we sort of meet, a lot of what we do in public health is education, but it's also realizing, who you're dealing with and what do they care about in their community, and being able to give them the resources specific to their community to deal with their specific problems. And this is especially true in Texas. We're humongous. And so the problems that we even have in this zip code in Houston are different from they have in another zip code just across town. And so that's something that we really have to recognize and deal with. And I think that successful public health interventions take that into account.
So I want to pivot just a little bit and kind of piggyback on a comment that Dr. Schuler was making that kind of introduced this concept of the business community, the business sector, and the role that they may actually have in public health. Dr. Schuler, could you talk a little bit about what has, in my view, been this emerging field of social innovation, social entrepreneurship, and how that sector is intersecting with really the goals of public health?
Well, there's a lot of enthusiasm. I'm a skeptic. That's my job. Clearly, I teach courses on social enterprise, social entrepreneurship, and kind of the holy grail right now are these win-wins, right? Double bottom line, triple bottom line, whatever they call it. It's kind of flavor of the day. The challenge always on the private sector, and I'm not here to disparage any of our private sector guests who might be in here, is that at the end of the day, you got to pay the bills. And if they don't think they can pay the bills by serving a public goal or a community goal, they're not going to be in it very, very long. They're going to look for ways to bail. Now, obviously, the private sector private sector has a lot of really talented people, really smart processes. They have delivery systems that can be really effective. And so I think there's opportunities to think of win-wins, and they may not be optimal win-wins, but they might be ways of moving, kind of moving things down the road. So I don't know. I may be less enthusiastic than you are, and maybe some of the other panelists want to chime in. I think it's a possibility. I just don't think it's a silver bullet. I think people try to solve these, silver bullet things, and I don't see it.
And does it bear explaining just by definition kind of what, would you all be interested in hearing more about what it actually is? I'm seeing some nods. So just kind of describing the sector as a whole, like what kind of businesses are social entrepreneurs getting into that intersect in any way with public health?
Maybe another way to ask the question is, recently with Amazon and Google and all sorts of things, they're jumping into this space, right? They're excited about this. And they're bringing a lot of energy into it, and so the question is, to your point, there's got to be something in it for them in order to be jumping into this, right? It's not just for community good, or is it just for community good? So your
And
thoughts?
Whole Foods might be one example.
We tried.
I don't know. You know, Whole Foods, you know, look, there's parts of town that don't have very nice grocery stores. They don't have any grocery stores. I just don't see Whole Food going to come in as a say. I don't. You know, the city of Chicago allocated all kind of public resources to put a Whole Foods in a low-income part of town. That was a pure transfer, in my mind, that was a pure transfer of public funds to a private sector company. Now, were there benefits in the community? I would think so. I would think that, you know, again, I don't know if they've been measured, and I haven't seen the research, but we could imagine that people in the neighborhood had some benefits, and it might have driven some economic development. That was probably the justification. It wasn't about health, it was about finance, right, of the city that probably drove that investment. I just see these as really poor investments.
One of the things that I'm very worried about is this real movement now towards precision medicine. Or what's the other term they used to describe? What's it? Personalized medicine. I'm worried that this potentially could drive a wedge even further between the haves and the have-nots, right? So somebody has cancer and comes to Baylor, MD Anderson, and has their whole tumor, the whole genome of their tumor sequenced, and they're able to identify a specific targeted therapy. What about somebody living in the 3rd ward or the 5th ward? What's that person going? I mean, maybe over time, the benefits of precision medicine will filter down to the community, but in the short term, I have some concerns.
So we've got a couple of minutes. I'd like to really just close by saying thanks to every one of you on the panel. This made for a very rich discussion, if you all can join me. So you've heard more of the policy perspective, a lot of funding challenges when it comes to the public health system. You know some of the players in the public health system, some that directly contribute to the provision of public health services. And then there's other systems in which the public health system interacts. So we talked about food retail, for example. There's other systems like the transportation system and public infrastructure, and just a whole array of agencies that are involved in really serving the public. Law enforcement comes up as another one. Emergency managers when it comes to incidents like Harvey. So there's so much more to learn, and I encourage you, if you haven't had a chance, to look at some of the materials that were provided in the course curriculum. And with that, I'd like to close and say thanks again.
Peter, do you know